Hey everyone, welcome back to all my listeners. This is episode 4 in season 17. Today is Wednesday, February 25th, 2026. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, you guys, so it is the last week of the month of February. Wow, this month just flew on by. Yes, it's a shorter month, but it definitely went by super quickly, in my opinion. So, this is a pretty hefty episode today. It is one of my favorites of the month that I deliver, and it is because it is going to focus on my Newsworthy fraud, waste, and abuse highlights for the entire month of February 2026. And of course, I'm going to be spotlighting some of those from the month's criminal and civil enforcement cases that I find newsworthy. And in my Trusty tip, I focus on my compliance recommendations for surgical dressings. And I'll go ahead and close out and round out today's episode with a remarkable quote on beauty, abundance, and innovation by Vincent Van Gogh. All right, you guys, let's get into it. So in today's Newsworthy, the month's fraud, waste, and abuse cases. The month of February saw 32 cases as of the recording of this episode. So let's go ahead and check out some of those cases that I want to spotlight. February saw AG's office securing indictments against Peabody Alcohol and Drug Counselor and her businesses for more than $850,000 in mass health fraud. The Massachusetts Attorney General's Office, the AGO, announced that a woman and her two companies, Recovery Journey Service, Inc., and RJ Recovery LLC, or RJ Recovery, were indicted by a statewide grand jury on multiple charges related to fraudulently billing Mass Health and Mass Health Managed Care Entities, or MCEs, for services they did not provide and for services that she and her companies were not qualified to render. The AGO alleges that, as a result of her conduct, Mass Health paid more than $853,790 for fraudulent services between February 2021 and July 2025. Each defendant is charged with one count of Medicaid false claims, Medicaid reverse false claims, and larceny over $1,200. Now, the woman opened RJS and RJ Recovery in 2020 and 2022, respectively, to purportedly provide support and recovery services to individuals struggling with addiction. The AGO alleges that despite advertising peer recovery coaching services, a service that is paid at a lower rate, she and her companies billed Mass Health for psychiatric, psychotherapy, and evaluation and management services, which are paid at a higher rate. The AGO also alleges that in many cases, these services were not rendered, including during times when there were no licensed clinicians on staff to perform these types of services. The AGO further alleges that she used the National Provider Identification, or the NPI numbers, of other licensed providers who no longer worked at RJS and RJ Recovery on claims that she submitted to Mass Health for services not provided. In using licensed providers' NPI numbers, the AGO alleges that she knew that she was not entitled to the payments she received from Mass Health, yet she never disclosed this information to Mass Health or returned the money. The AGO's Medicaid Fraud Division is a Medicaid Fraud Control Unit, a MAFUCU, annually certified by the U.S. Department of Health and Human Services to investigate and prosecute healthcare providers who defraud the state's Medicaid program, Mass Health. The Medicaid Fraud Division also has jurisdiction to investigate and prosecute complaints of abuse, neglect, and financial exploitation of residents in long-term care facilities and of Medicaid patients in any healthcare setting. Individuals may file a Mass Health fraud complaint or report cases of abuse or neglect of Medicaid patients or long-term care residents by visiting the AGO's website. The Massachusetts Medicaid Fraud Division receives 75% of its funding from the U.S. Department of Health and Human Services under a grant award totaling just over $6.4 million for federal fiscal year 2026. The remaining 25%, totaling over $2.1 million for fiscal year 2026, is funded by the Commonwealth of Massachusetts. Now, these charges are allegations only, and the defendant is presumed innocent until proven guilty. February also saw Attorney General Bonta announcing 7 arrests for hospice fraud. My office is on it. Now, the California Attorney General Bonta announced the arrests of and filing of multiple felony charges against 7 individuals for hospice fraud in Monterey County, California. Among the individuals arrested is the owner of Compassionate Touch Hospice and Spiritual Touch Hospice, 2 co-owners of Fountain Hospice, 3 doctors, and 1 nurse. The arrest and charges are the result of investigation by the California Department of Justice, the DOJ, and the U.S. Department of Health Service Office of the Inspector General. Now, the DOJ received a referral from the California Board of Registered Nursing after fraudulent activity was discovered and associated with Spiritual Touch Hospice and Compassionate Touch Hospice. Now, DMFEA's multi-year investigation revealed a sophisticated conspiracy to defraud Medi-Cal and Medicare and involve the owners, doctors, and nurses of Spiritual Touch Hospice, Compassionate Touch Hospice, and Fountain Hospice. The defendants owned, operated, or worked for the 3 hospice companies simultaneously. They recruited, enrolled, and certified patients for hospice services who did not suffer from a terminal diagnosis. Some of these patients did not know hospice was intended for patients who were terminally ill, or that they were even enrolled in hospice. To avoid suspicion, the defendants transferred several patients between the 3 companies after 6 months and continued fraudulently billing for hospice services. The total loss to Medi-Cal and Medicare is over $3.2 million. On January 30th of 2026, the DMFEA filed felony charges in Monterey County Superior Court against a head nurse, 3 medical directors, and 3 owners, alleging violations of false or fraudulent claims, conspiracy to commit a crime, with an aggravated white-collar enhancement. The DMFEA is a California Department of Justice unit whose mission is to protect citizens and the state's medical program from those who defraud taxpayers and divert state health care resources. The investigation would not have been possible without the collaboration of government agencies and those who reported the incidences of Medi-Cal fraud. If you suspect Medi-Cal fraud or elder abuse, you can report these incidents at https://oag.ca.gov/DMFEA/reporting. Now, it's important to note that a criminal indictment contains charges that are only allegations against a person. Every defendant is presumed innocent until proven guilty. February saw St. Margaret's Center agreeing to pay $1.3 million under the False Claims Act. Nursing home that provides services to chronically ill and disabled children admits that care did not consistently meet federal and state standards. Now, the first Assistant United States Attorney Sarcone III announced that the Center for Disability Services Holding Corporation, doing business as St. Margaret's Center, or SMC, a skilled nursing facility located in Albany, New York, had agreed to pay $1.3 million to resolve allegations that it violated the False Claims Act by billing for care that was worthless and falsely attesting that it had implemented a compliance program that promoted quality care. Now, this particular settlement resolves allegations that between January 1st of 2018 and December 31st of 2023, SMC provided care that was grossly substandard and therefore worthless. During this time, New York State surveys or inspections revealed that SMC did not consistently provide sufficient nursing staff, ensure that residents were free of significant medication errors, or provide respiratory and tracheostomy care and suctioning. During one such survey, the New York State Department of Health, the NYSDOH, determined that SMC failed to adequately supervise 3 residents, jeopardizing their health or safety. NYSDOH placed SMC into quote-unquote immediate jeopardy status for over a month in 2022. Based on NYSDOH's findings, the Centers for Medicare and Medicaid Services placed SMC on its special focus facility list, in which they identify nursing homes throughout the United States that have a history of serious quality issues. As a condition of receiving federal and state Medicaid dollars, SMC annually certified that it adopted and implemented an effective compliance program that addressed quality of care. SMC admitted that its compliance program failed to meet the statutory compliance program requirements. For example, SMC's compliance officer admitted under oath that they had, quote, no idea how to identify potential compliance risks associated with caring for medically fragile infants and children, and was unaware that SMC had been placed in quote unquote immediate jeopardy status by NYSDOH. SMC's compliance program did not include quality of care as a potential risk area until March of 2023, after the government investigation in this matter had commenced. Contemporaneously with the settlement announced, SMC agreed to enter into a Quality of Care Corporate Integrity Agreement, or CIA, with the United States Department of Health and Human Services, Office of Inspector General, the HHSOIG, which will remain in effect for 5 years and address quality of care and resident safety within SMC. Now, the settlement resolves a whistleblower lawsuit filed under the qui tam provisions of the False Claims Act by 2 former SMC employees. The act allows private persons to file civil actions on behalf of the government and share in any recovery. Under the settlement, the whistleblowers will receive approximately $247,000 of the settlement proceeds. Now, February also saw a Highland physician sentenced to 97 months in prison. An Indiana woman was sentenced after pleading guilty to healthcare fraud. The female physician was sentenced to 97 months imprisonment, followed by a 1 year of supervised release and ordered to pay over $19.1 million in restitution. As part of her plea agreement, she was required to forfeit significant assets, including jewelry, vehicles, musical instruments, and the contents of a number of bank accounts. She also agreed to sell real estate and other luxury assets purchased using the proceeds of her crime in order to fulfill her obligations to repay the fraudulently obtained funds. According to documents in the case, as the physician and sole owner of the Center for Otolaryngology and Facial Plastic Surgery, she billed Medicare and private insurance for thousands of balloon sinuplasty procedures that she did not perform. A balloon sinuplasty is a procedure designed to treat chronic sinusitis by using a small, flexible balloon catheter to widen the drain-blocked sinus passages. She sought approximately $50 million for these non-existent procedures, for which she was actually paid almost $20 million. Approximately $460,000 of the fraudulently obtained funds were paid by individual patients in the form of co-insurance payments. And now it's time for my best practice tips in Trusty Tip. All right, so for Trusty Tip today, I wanted to focus on the latest MLN Connects that just came out last week. Now, I cannot stress how important it is to understand coding guidelines and coverage indications and limitations when it comes to billing for surgical dressings. Now, the MLN states, quote, in 2024, the improper payment rate for surgical dressings was 57.6%, with a projected improper payment amount of $177 million, end quote. Now, in my opinion, that is a lot of projected risk onto the limited Medicare trust fund monies. So we need to be able to know these 3 things. Number 1, the billing codes here for our surgical dressings. Number 2, the denial reasons and how to prevent them for these types of surgical dressings. And finally, 3, we need to be able to understand what the refill and documentation requirements are for these types of surgical dressings. The MLN also goes over examples of improper payments due to insufficient documentation. Now, first, who are the affected providers here, right? We have to understand that the affected providers include only those that are the treating practitioners as well as our durable medical equipment, those DME suppliers who bill for surgical dressings. That's it. Those are the affected providers. Now, let's go back to that first item that I stressed upon, right? What are the codes here that are applicable to these types of surgical dressings? Now, there's going to be a variety of our HCPCS codes. There might be CPT codes, but in general, based on Medicare and the guidelines that I will go over, these are HCPCS codes. So there are also local coverage determinations, or LCDs, specific to our surgical dressings, specifically L33831, that has the list of current HCPCS codes. Now, when you dig into the LCD, which I love to do, you will understand that there will be a list of A codes in the HCPCS manual. Now, these A codes are for the surgical supplies, and they include things like tape, or compression bandages, or gauze, or collagen sheets, or foam dressings, and items like that. And there are a lot of them in this A range of our HCPCS codes. Now, you'll also need to pay attention to the Coordinating Local Coverage Article, the LCA, which is titled Surgical Dressings A54563. Now, you're going to have to also understand and apply that article based on the standard documentation requirements for all claims submitted to DME Max, right? There's a separate article that you have to be aware of. Bookmark that as well, especially if you are billing out these types of surgical supplies, if you are a DME supplier. And that article is A55426. Now, if it applies to your organization, your entity, or your practice, be aware of the National Coverage Determination, the NCD, that also exists for our porcine skin and gradient pressure dressings. And that is under NCD 270.5. Now, let's move on to that second point that I stressed, right? Second, what are the denial reasons? That's really important when those EOBs come back to you. And how can you prevent those types of denial reasons? So, no documentation, again, according to the MLN that was issued a week ago, no documentation accounted for 48.6% of improper payments for surgical dressings during the 2024 reporting period, while insufficient documentation came in at 43.8%, incorrect coding came in at 1.3%, and medical necessity came in at 0.4%. And finally, other errors came in at 5.8%. And all of those items that I just mentioned caused improper payments. Now, that vague bucket of other errors will include things like duplicate payments, non-covered or unallowable services, or ineligible Medicare patient errors. Now, how do we prevent our denials? Well, you're going to have to understand the requirements for a qualifying wound. So a lot of these surgical dressings are going to apply to wound care patients. So CMS covers surgical dressings for a qualifying wound. And a qualifying wound is either a wound caused by or treated by a surgical procedure, or a wound after debridement, regardless of the debridement technique. And those techniques include, but are not limited to, surgical debridement, mechanical debridement, chemical debridement, or autolytic debridement. And you're also going to have to be able to understand the requirements for a qualifying dressing. CMS considers eligible products classified as surgical dressings to include primary dressings or secondary. Now, primary include therapeutic or protective coverings applied directly to wounds or lesions either on the skin or caused by an opening to the skin. Secondary ones are for those needed materials that serve a therapeutic or protective role to secure a primary dressing. Examples of secondary dressings include adhesive tape, roll gauze, bandages, and disposable compression material. And the most important item in all of this, in my opinion, which I've stressed again and again and again, are those documentation requirements. That's where I continually see under documentation. So where the LCD and the LCA are not being followed, right? So documentation is under-documented. Now, for initial wound evaluations, the treating practitioner's medical record, nursing home record, or home care nursing records must specify all of these things. And our LCD also lists this out really, really well, but the MLN has come out and they have quantified all of these items as well. So specifically, initial wound evaluations must include the type of qualifying wounds, the location, the number and size of qualifying wounds being treated with a dressing, whether that dressing use is primary or secondary, or for a non-covered use, for example, for a wound cleansing. We also have to include amount of drainage in our documentation. We also have to include the type of dressing. For example, is it a hydrocolloid wound cover or is it a hydrogel wound filler? We have to get specific. We also have to include the number or amount used, one at a time, right? How many items are we actually using? Then we have to include details about frequency of dressing changes. We also have to talk about any other relevant clinical information. Now, the patient's medical records must include the clinical information and the reasonable and necessary policy requirements about the type and quantity of surgical dressings, which the treating practitioner or their designee must update monthly. So we have to make sure all of that is documented as well. CMS requires this evaluation of the patient's wound unless the medical record documents and justifies why the treating practitioner cannot evaluate within this time frame and documents what other monitoring methods showed the patient's need for ongoing dressing use. And I have to implore that our providers do a much more robust job in their documentation, because I've seen many a valid reason for claims to be denied upon documentation review, because we're simply not following the LCD that is in existence for these types of A codes. Now, CMS expects weekly wound evaluations for patients in a nursing facility or for patients with heavily draining or infected wounds. A nurse, treating practitioner, or other healthcare provider involved in the patient's regular care can do the evaluation. This person may have no financial relationship with the supplier. This prohibition does not extend to treating practitioners who are also the supplier. Now, moving on, the weekly or the monthly evaluation documentation must also include the type of each wound. For example, is it a surgical wound? Is it a pressure ulcer? Is it a burn, etc.? We also have to be able to have itemization of the wound's location. Where is it located, right? We have to be specific and not vague. Further details must include the wound size, the length and the width and the depth. We also have to talk about the amount of drainage, as well as any other relevant wound status information. The supplier must document and date the source of this information in their records. Now, the frequency of recommended dressing changes depends on the type and use of the surgical dressing. When providers use combinations of primary dressings, secondary dressings, and wound filler, frequency of changes in individual products should be similar. Now, for this particular policy, the product in contact with the wound determines the change frequency. So we have to pay attention to what product we are using. CMS does not consider the use of a combination of products with differing change intervals as reasonable and necessary. So make sure we're not mixing and matching products, because they will have a no-no on that, especially if those change intervals are different. So they will not consider that to be reasonable and necessary. For example, it is not reasonable and not necessary to use a secondary dressing with a weekly change frequency over a primary dressing with a daily change interval. They will deny these claims as not reasonable and not necessary. Now, finally, third, we must know about those refill requirements. Now, for our DME POS items, our durable medical equipment, prosthetics, orthotics, and supplies items, right, provided on a recurring basis, you've got to base your billing on prospective and not retrospective use. So, documentation requirements have to include, to justify payment, we have to meet specific requirements when ordering our DME POS. CMS requires a new order every 3 months for each dressing used. Example of improper payments due to insufficient documentation for surgical dressings. Now, the example that they give in the MLN, and I've supplemented it with a couple of extra detailed points as well. So an example of improper payments due to insufficient documentation for this very type of item, surgical dressings. A supplier bills the claim for HCPCS code A6203, which is for a composite dressing, sterile, pad size, 16 square inches or less, with any size adhesive border, each dressing. And the supplier submits the following documentation per the review contractor's request. So their MAC in their region requested this information. They wanted a standard written order with the range of the correct HCPCS coding. They also asked for the treating practitioner's medical record that has adequate medical necessity information. They also wanted the wound evaluation and medical records, and they also wanted the refill request. Well, things that I see that are missing is that they have a standard written order with this range of HCPCS codes and not that specific A6203, right? Which is what the supplier put out on the claim. So instead of documenting a specific code A6203 or with the description of the item itself, they are giving a vast range of those A codes. So that is simply not good enough. And then when they are submitting that treating practitioner's record, that is going to be inadequate. They are not providing enough medical necessity information. So that would be inadequate. When they're submitting wound evaluations and medical records, they're only doing it partially, right? I listed out a whole laundry list of items that have to be included in that wound evaluation. And then when there is a refill, that request has to be somewhere in that medical record as well. So we have to submit that refill request. So those are things, really good examples of when things are insufficient in documentation. However, those improper payments have already been made. So we need to make sure that we have supporting documentation to make sure that we can consider winning on that appeal that we are trying to gain our reimbursement back. So I see this type of thing very, very often, that supply code must be exact to what is prescribed, not a range of HCPCS codes. That treating practitioner has not clearly stated what the supply is for and why it is needed in the treatment and management of their patient. The LCD is not adhered to. There are missing elements of wound care evaluation. And finally, there is no refill requested by the patient as applicable to the specific surgical supply, and or the treating practitioner did not include an order that had an applicable supply code with refills and a date span or a number of refillable surgical dressings. And finally, I focus Season 17 Spark on beauty, abundance, and innovation. I want this 16th season Spark to be filled with our world's thought leaders, writers, artists, philosophers, everyone whose words provide us with their insights on beauty, abundance, and innovation. So, in this week's inspiring quote in Spark is from Vincent Van Gogh. If you truly love nature, you will find beauty everywhere. Absolutely true, right? I love this quote on beauty and abundance, all rolled into one. If we change our outlook, our mindset towards positivity, radiance, and limitless possibilities as we look around the landscapes that surround us, I believe we have a better chance of achieving the joy and the serenity we all aspire for. I'm happy Vincent Van Gogh's spark still burns brightly and can still inspire so very many. All right, you guys. Well, that wraps up today's episode. I really hope you got a lot out of that. I know the month's fraud, waste, and abuse cases were shorter, with only 32 that clocked in as I record this episode, but they were really, really good ones, right? So much that we can take away as educational professionals, compliance professionals, providers in my listening audience here. There's a lot that we can take away back to our own compliance programs that we have at our organizations that we can really make improvements on, so we can make sure that we are doing things correctly the first time. So we avoid this type of post-payment scrutiny, because that really is what's going on here in my monthly spotlights for fraud, waste, and abuse, right? All of these things have been done in the past, as I always disclose, right? All of these things have been looked at retrospectively. So, the government has a way of extrapolating the data and ballooning things up out of control again, which is why we see the number of dollars in the millions where people are paying back, right? And there's a lot that I know I learn each and every month when I share these particular DOJ cases with my audience. There's so many notes that I can take back and document, so I can keep this type of research for myself. So when I have clients in this particular specialty, it's just an opening eye. It's very, very welcoming to see where there have been so many pitfalls in the past that I can help prevent for my new clients in this particular space, whatever the specialty may be. So I really do hope that the fraud, waste, and abuse newsworthy items that I talk about from month to month are really helpful, because I do try to pick different variety of items, from the COVID-19 scams to all of the DME scams to all of the radiology testing types of services that are misunderstood, right? Don't forget about the big bad modifier 25 that is forever under scrutiny. All of those evaluation and management types of codes that are still under a work plan. So there's lots that our industry is being looked at. So I really do love to provide as much education as I can to my audience, to my providers, and to my colleagues. So really hope you got a lot out of it. I know I definitely did for the surgical supplies. I deal with a lot of DME cases in the everyday work I do. And specific to me was that refill stuff. I've had to unfortunately fault a lot that I've seen in terms of that refill request from the patient for specific HCPCS codes was missing, so you really have to read the fine print of all of those particular supplies that you are dealing with in the HCPCS book. So, and especially with all of the new changes that are happening in wound care, everything that has happened for January 2026 moving forward in wound care, I know there's a lot that is going to pertain and apply to these surgical supplies specific to what I talked about today in the A code range. So lots to think about and digest, but we are wrapping up the month here. So I really hope you guys have an incredible week ahead and a very, very strong start to the month of March. And you guys are going to be in for a treat. Next week is going to be another spotlight feature, another highly regarded professional that I have on speed dial. So I know you guys will love it, and I can't wait to see you guys next week. Thank you so much for listening on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.